The first speaker is Lucy Brogden. She's Commissioner with the National Mental Health Commission. Lucy has a strong commitment to helping others and building stronger communities. Her primary areas of focus are mental health and wellbeing and suicide prevention, particularly in the workplace and the community. She takes an evidence-based approach to problem solving and social investment and draws on her own lived experiences and that of her family. So if you could please welcome Lucy.
Thanks, Peter. Excellent. So before we begin proceedings today, I would like to also acknowledge and pay respects to the traditional owners on the land where we're meeting today, the Gadigal people of the Eora Nation. It is on their ancestral lands that we are meeting to share our knowledge, understanding, research and learn from each other. And it's important that we recognise the knowledge that's embedded forever in Aboriginal custodianship of country, and particularly the Aboriginal community, the First Nations people's powerful understanding of social and emotional wellbeing. And as a Commissioner on the National Mental Health Commission and as the co-chair of the Australian Advisory Group on Suicide Prevention, I am very mindful that while the Australian suicide rate sits at slightly under 13 per 100,000, in some of our Indigenous communities that rate goes up as high as 74 per 100,000. It's a tragedy for all of us and a gap that we need to close and work on. I'd also like to acknowledge those of you in the room today with your own lived experience of mental illness and those of us that love and care for people on that journey. Today we're going to look at leadership and the question of suicide prevention from the highest level at the government policy level right down through the speakers to activities and efforts that can be done in your own workplaces. As a psychologist, you can't really talk without quoting Freud. And so I like this comment from Freud that love and work are the cornerstones of our humanness. And I'd like to talk about love all day, but I hope what you'll see is that love and work do go together. And a lot of what we can do in our workplaces comes from love and caring for each other as human beings. Very late in my own professional career, I came to realise that you need a philosophy to inform your own practice in whatever that might be. And my academic research in mental health in the workplace is focused more on professional services, particularly lawyers. And I came across this philosophy from the Emperor Justinian, and it now resonates for me and informs all that I do, that the well-being of the people is to be the highest law. And if we actually put that well-being concept at the top of anything we do in any workplace, it's hard to go wrong if that's what motivates our efforts and behaviour. I also chair the Mentally Healthy Workplace Alliance as part of the Commission's work, and I'll talk about that a little bit more. But when I talk about mental health in the workplace, I try and get people to focus beyond yoga and fruit bowls. I go into many workplaces and they tell me about their safety practices and they're fantastic, and then when it comes to mental health, we have yoga, we have healthy eating, and it kind of ends there. And our people still aren't happy and they're struggling. To try and focus on the positive, the hashtag I would like to work with is that good work is good for you, and we know that. To try and create workplaces with good work is a very protective factor for people. We've heard a little bit about the statistics today and the high rates of suicide in populations, and when I do go to conferences like this, I am struck by the number of organisations that say, this doesn't apply to us, we don't have anyone with a mental illness in our workplace. We've not been touched by this. And I can't play poker because I can't hide the look of disdain that comes on my face when people say that. If we look at those numbers, there is no way that there's a workplace that has not been touched by mental illness or suicide, directly or indirectly. The population affects a large, significant, and touch all of us. The distribution of illness is significant to understand and appreciate. There are people coming in and out of our workplaces every day. There are customers, clients and families living with mental illness every day, and we need to work out ways to accommodate and support that. From the highest level and from an economic perspective, which is a little bit dehumanising, but it's a huge cost to government. And we hear regularly about the reform structures that government has in place. They talk about tax reform, productivity reform. But we would argue, based on the research we've done at the Mental Health Commission, that actually tackling mental health in our community has a higher GDP return than many of the other economic levers that are trying to be played with at the moment. If we can improve the mental health system by 25%, that would deliver us a 1% return on GDP. For every 10% gain in mental health, that's a 0.4% increase. These are significant numbers. But why is it relevant in an industry or workplace approach? Because it's our organisations that can contribute and build the GDP of our country. If we come down to a more micro level, PricewaterhouseCoopers did some work for us a couple of years ago that showed that for every dollar invested in mental health and wellbeing in the workplace, there's on average a $2.30 return, and that can break down by industry if you're interested in the data further. The Mental Health Commission has an operating philosophy called the Contributing Life Framework, and I share this with you to show you that one of the pillars of that philosophy is that everybody is entitled to have something meaningful to do and to have something with purpose, and that comes from our workplaces often. It can be paid work or volunteering, but it's important that we provide people with meaning. And if we go back to the presentation this morning, it's allowing people to feel needed by their families, by their communities. In 2014, the Commonwealth Government asked us to do a review of the Commonwealth's expenditure around mental health and suicide prevention in Australia, with no new money. And that was fine. It's a creative challenge for us. It's always good to have tight boundaries in which to operate. But we recommended a systems change, systems reform for mental health. And there are enough of us with grey hair in this room to have lived through many systems change approaches, from deinstitutionalisation last century through to different tweaking at the margin. But we really wanted to put forward a person-centred approach. And I shared this slide with you. You may not be interested in public health reforms and systems, but I wanted to show you that you can see that the workplace is really close to the centre of this systems reform. We see workplaces being integral to not just promoting wellbeing, but they provide incredible protective factors to people's wellbeing in their mental health issues and often in their suicidality. Come on, slides. There's been a lot of interest around particularly the suicide prevention policies and debates, and I just wanted to track through some of that history because in the review we recommended to the Commonwealth a new approach to suicide prevention in Australia, a more regionally focused approach. Communities know their people much better than Canberra will ever know what's going on for the communities individually. And that was our proposal, and it was picked up by the Commonwealth. The PHNs, the 31 new health entities across the country, are charged with developing their own suicide prevention strategies, and they're starting to work on those. This is a bold change and approach for government to actually acknowledge that communities might know what's in their best interests. There are a number of election commitments last year around extra funding and trial sites, and I'll talk about those a little bit. And when I sent these slides in last week, we were at a 5th National Mental Health Plan draft, and I had a slide that will come up now that said that we have multiple suicide prevention plans across the country, but that there's one missing. And pleasingly on Friday, the COAG ministers agreed to change the name of the 5th National Mental Health Plan to a 5th National Mental Health Plan and Suicide Prevention Plan. And they acknowledged that within the draft of the current 5th plan, suicide prevention needed bolstering. So for us as a sector, this is a significant win and acknowledgement by governments at the national level and across the states and territories that suicide prevention needs a coordinated approach across the country. At the national level, we do have 12 significant trial sites starting off in various communities around the country. Townsville will be a veteran suicide trial site, and more information about that trial will be announced later today when Minister Tehan and Minister Hunt release a review that we've done on suicide in the defence and veterans populations. There are trials in remote communities. There are trials being run in more urban communities. But they're looking at the at-risk populations that we've identified in terms of the Indigenous population our men aged 25 to 54, young people, and the veterans. This is a targeted approach to suicide prevention. We know that one size does not fit all, that we need specific messages for people and specific messages for community. One of the cohorts that I would like to see more closely focused on is actually our older population, who have a significant rate of suicide, and yet we tend to turn a blind eye to that issue. The PHNs will run these trials with an obligation to report back and share their learnings and evidence. We're quite good in government policy areas at developing great ideas, sometimes rolling them out well, but we're not good at evaluating. And one of the things we want to see from the trials is that we do have good systemic evaluation of the programs so that we know what works and what doesn't work. For too often we've been spending a lot of money and not understanding the outcomes, and really it's about outcomes measurement. At the national level, through the advisory group on suicide prevention, we're looking at a tighter intergovernmental approach. Nothing gets me more frustrated than the tennis that I see go on between states and territories and the Commonwealth over whose responsibility this is, or as we heard from Gus earlier, between departments saying whose responsibility this is. Our view at the National Mental Health Commission is that our biggest levers in terms of mental health and suicide prevention do not sit in health at all. They lie in education, in employment, in training, in housing and social services. Building stronger communities is a very protective factor that we need to work on. So we're looking to bolster that intergovernmental approach. We're looking to actually collect data in real-time situations. We can't properly address problems that we don't understand. And I don't want us to get bogged down in waiting for the data to come in. There's things we can be doing all the time and we're trying to push for that. But at the moment we don't have a good understanding on what the suicide picture looks like. And I've heard many times from people the plural of anecdote is not data. And we need to capture that information so that we can help communities plan to respond to suicide. It's not good enough that in my own community on the Northern Beaches, we have a 2-year time lag on the data that we have around suicide prevention to work out how to respond. We need data straight away to be able to jump in and identify hotspots and clusters and respond as a community to the issues that are going on for us. We want to provide more support too for carers and families, because those of us that love and care for someone living with suicidality, that's a tough journey to go on. We are the primary supports. We're the first people often come to and lean on in that moment of crisis and need. That crisis can be fleeting or it can go on for years and years. And it's understanding the power and role of those families to be protective. It's also understanding that we know that if you are in a family of suicide, you are yourself at greater risk. And how do we wrap around and protect those people in those communities? And it's trying to adopt a continuous improvement approach to suicide prevention in this country, to keep moving, to keep understanding the issues at hand. It's striking to me that if my child gets measles or even foot and mouth disease, that's notifiable and the resources come in and step into the community and respond. If I have a family member that attempts suicide or dies by suicide, it's merely interesting and the data will come through the system 2 years later. And that approach does not work. In terms of the workplace, the National Mental Health Commission created in conjunction with a number of organisations the Mentally Healthy Workplace Alliance to really try and focus on how we can improve the mental health of our population through the workplace. I teach organisational psychology to third-year students, and every essay I read from them starts with, we spend the majority of our waking hours at work. And the reality of that is that it's true, we do spend the majority of our waking hours at work. So the Alliance brings together groups such as the Business Council of Australia, the ACTU, Australian Chamber of Commerce and Industry, the Australian Industry Group, Beyond Blue, Superfriend, who's probably known to a number of you, University of New South Wales, I'm trying to think, not leave anyone out, but a range of people who all have a strong interest in trying to create stronger workplaces for our people. And we've been looking at a range of activities around the world and nationally to see how we share best practice and learning. We're looking at what the Canadians are doing around the standard for mental health in the workplace. We're looking at the UK's wellbeing achievement targets. And we're looking to Germany, where they have an industry approach to suicide prevention and mental health in the workplace. And it's a great credit to mates in construction that you lead the way in this industry approach to wellbeing and protecting your members. This is important to all organisations. The cost of this to business is significant, $10 billion a year. We can't ignore these real numbers and not real numbers. When I work with law firms, they tell me things like absenteeism and presenteeism aren't real money. And I say to them, great, if I save that not real money, I won't charge you a fee, I'll just take the saving. And often that's enough to engage them in the understanding that these are real. The other key point I want to make in the workplace, and I like the comment from Peter Drucker, is culture eats strategy for breakfast. A number of organisations come to us and say, oh, I've got all these beautiful policies and manuals and training programs, we're sweet, we're fine, we've got this covered. The reality is the regulators will find that fascinating, interesting for a moment, but they're going to come in and look at the way you do things around your organisation. And they have the powers to come in often without notification to look at what you're doing and understand and tap into that culture. The Alliance wants to help people design programs to improve the mental health, wellbeing and safety of their organisations. And we did a literature review a few years ago that's publicly available to share. And it starts with smarter work design. It promotes and facilitates early help seeking, having champions in the workplace to allow employees to disclose that they're struggling when they're having trouble, to build that positive and safe work culture, to enhance personal and organisational resilience. And I try and move away from the word resilience now. I prefer resourcefulness. Resilience suggests a deficit, whereas I think we've all got strengths inside us that we can tap into. It's supporting recovery, and this can be a challenge in workplaces around how do we best support someone's recovery journey, and increasing the awareness of mental illness and strategy. But it's quite simple at the end of the day. Good old Hertzberg, who I'm a big fan of, said if you want someone to do a good job, give them a good job to do. So it all comes back to good job and work design being highly protective. I'll just finish up with a few key resources that I promote when I speak about mentally healthy workplaces. The first one is the Heads Up website that we developed through the Alliance and in conjunction with Beyond Blue. There's resources for all organisations there to look at your own practices around mental health in the workplace and some other specific tools that people find quite helpful. One particular on disclosure of mental illness in the workplace. And there's tools there for managers but also for individuals. And another tool that I'm really pleased to share is the Conversations Matter tool developed by the Hunter Institute of Mental Health. And it's a tool around how to have a conversation around suicide. But I think it's a great tool for workplaces just on difficult conversations generally. I want to finish up there so that there is time for questions, conversation, discussion, feedback. So thank you all. So we have some progress. We now have uniform reporting across all the states in terms of the police reporting, which might seem surprising that that's just something that we've achieved by 2017. That will go a long way. We have the coroners working proactively around uniform reporting measures, but there's a certain lag there. And what's frustrating to us is the shadow systems that are popping up across the place where very well-intentioned police and ambulance services are capturing information and sharing them back into communities, but that's not happening everywhere. So one of the priorities for us is that good data analysis. We're working with the ABS around some of their data work, and there's so many acronyms with IPA and AIHWA and a number of organisations to try and capture the image faster and more accurately. Yes, Safe Work Australia is part of that. And Safe Work Australia is also a member of the Mentally Healthy Workplace Alliance.
Jane, yes.
Yeah, talk about strategy and culture. So what do you see as a good culture? What does that look like?
From our perspective around mental health in the workplace, it's a culture where people feel safe to disclose and to come to work and live with their mental illness and not have to hide away. But generally, a culture that's transparent and open is what we're hoping for, not one where people need to feel shamed. And it's my dream that if I talk about having a mental health day, people don't giggle and laugh and think that that's just a funny thing to do. it's a legitimate thing that I can openly put my hand up and seek to do. My actual desire would be that you can have leave without having to justify whether it's for mental health, physical health or carers leave, but at least that you can have a mental health day, that you don't have to have food poisoning or something else on a regular basis. I think the treatment options are highly variable, and I'm a psychologist, so I won't pretend to go into the various methods of medications. But we do see high variability around the medication rates and practices across the country. And as the National Mental Health Commission, that's a question we put back to the jurisdictions on a regular basis, because we see those patterns of prescribing and ask what's going on and try and shine that light of accountability to say, why is it that we see this practice in this particular region and it's not going on there, and what are the best practice models?
Any further questions? Yeah.
A lot of, and including some of the sponsoring organisations on that.
Look, that's where I put job and work design number one on these issues. And I say to organisations that profess to, hand on their heart, one of my big bugbears is hot desking. And I don't know if your organisation hot desks, but I just asked those organisations what evidence they looked at around the benefits of hot desking before they embarked on these things. And, a number of organisations will tell me about the reduction in rent, but I ask about the improvements to productivity and the impacts on wellbeing, and not many organisations look at those issues. To me, if you're embracing good job and work design, you look at the whole impact of the equation. And whether it's government policy or an individual's corporate decision, some of these things that can look like a good idea at the time and might have financial impact on the short run, can have significant bottom line impact in the medium to longer term. And I think that's why I encourage organisations to take a truly evidence-based approach to the work that they do around job and work design, and make sure that they're looking to good evidence when they bring these in, and think not just about the short-term savings, but the longer-term costs that might be associated with what they're doing.
Back.
You mentioned about collection of data. My question is, how are you going to overcome those barriers?
Sure. So in terms of what we do in multicultural Australia and the called populations that we're trying to reach out to, this is a huge issue that we're looking at from a workforce planning perspective, because language is a big barrier. Culturally appropriate treatment is important. And I think one of the things that we've actually learnt from working with the First Nations people is that we need to have culturally informed care practices. And to do that helps to build trust in community and effective therapeutic relationships. So one of our work agendas is to look at workforce planning and try and accommodate those needs. It's not good enough when I go around various programs to say, we've addressed that, we've just translated all the brochures into this language. We need practitioners trained in culturally informed care as a starting point. We have learned a lot about trauma-informed care and how we apply that, particularly to the vulnerable migrant populations coming in, the refugee populations, and how we share that information, because it's my fear that what we're seeing in the Indigenous populations may well play out in some of the more vulnerable populations, in the migrant populations in the medium term. So we need to capture that learning and apply it more globally across the country.
Yes?
Just in terms of...
Absolutely. In terms of the data, again, it's lagging, but I think what we are seeing is greater awareness of what risk might look like. And it's... we saw with the fluctuation in the milk price and the vulnerability that was facing the dairy industry, particularly in Victoria, a lot of the NGOs and the government appreciated very quickly the risk and pressure that was going to put on to that community, and have sent in additional resources and are looking at responses specific to the dairying community in Victoria to help them through, and not just the farmers themselves, but all the adjacent industries that support that. We've seen similar programs coming through in Whyalla, where they're going to have big job losses. And I think this is the forward planning that we can all do, whether it's from a government level, and I'll let the next speakers cover off sort of the industry and company levels, but to be if we put the well-being of the people at the top of what we do in that decision-making process, and then how are we going to protect that with the actions that we're planning to take, I think that goes some way to starting to be proactive around the services that we wrap around. There's a great little case study that Caterpillar shared where they put people, and I don't want to steal a mental health first aid story, but mental health first aid went in and did some great training down in Tasmania for the Caterpillar company. A few years later, there were major structural changes and that company was going to be halved. And that had huge consequences, not just for the organisation and the workers there, but for the whole town. And they found that the employees skilled in mental health first aid were able to support not just the organisation staff, but to start to help the community itself come to terms with the issues and the pressures and the emotions that were coming from that change. So I think as we destigmatise, as we take what Paul was saying about skilling up communities to be the gatekeepers, to have that greater awareness, we inevitably start to build that more proactive response to these things rather than sitting back and going, oh, we should have seen that one coming.
Towards the end. Thank you very much.